lên trình bày về cái lựa chọn phẫu thuật thích hợp trong điều trị béo phì. So I'm glad to invite Dr. Jin Chen to give a lecture on how to choose surgery for the obesity management.
Trong đó có cả cái câu chuyện sức về những cái rủi ro về những cái
I'm very proud to thank you for inviting me to this speech, and I will introduce myself. I'm a Dr. Chuyên, and I'm the Director of Biologic Surgery of Kaohsiung Veteran General Hospital. Today, the topic is the metabolic and the bariatric surgery. And at first, we know neuro guidelines point out that obesity and metabolic surgery operation are no longer simple consideration in specific condition. There are expected recommendation. Especially over the 2 decades, bariatric surgery operation rapidly increased in number, and as the laparoscopic surgical technique improve and the equipment is so progressed. Not only the new technique emerged in obesity surgery, but also new hormone investigation that was made on endocrinology response of organ and the embryonal foregut and the hindgut theory, encourages surgeon to attach with more desire than able to surgery. So by obesity surgery, let's make clear that operations are for the treatment of obesity disease, not just the weight loss. Today's topic is how to choose a proper procedure for metabolic surgery. We will see the definition and current indication for obesity and the metabolic surgery. The second topic is the tips, tricks, and the complication of the surgery. So we want everybody know the prevalence of the obesity is one of the major public health problems for the modern world, especially in Europe or Taiwan or America. And obesity will cause the chronic disease, including cardiovascular disease, diabetes, metabolic syndrome, and many cancers. From 1918 and 2013 show that obesity-related deaths are 3 times more than the fatalities related to the malnutrition and the starvation. In 2016, WHO identified we can see the 39% of adult men and women with the BMI more than 25, and it defined the body weight, overweight. And further, 11% of men and 50% of the women with the BMI more than 30 is defined as obese. We also see that 80% of the children adolescents who are overweight or obese. So more than 10% of the world population got obesity. So we introduced a new name called obesity. When the surgery began, and we can trace to the 1950s, the jejunal bypass surgery are the earliest, the master obesity and the metabolic surgery. It's an effective treatment for weight loss and dyslipidemia. But in the past, we found serious metabolic complication happen. So the jejunal bypass failure till the 1966. Dr. Mason introduced the first gastric bypass operation. It's simple. We cut the stomach with the haranto, and we pour the jejunum to the stomach, and we got the gastrojejunal anastomosis. But it's mostly communication is by the reflux. So then we changed the method to the standard loose and wide gastric bypass. Current concepts of bariatric surgery and metabolic surgery and the recent metabolic study. The mechanism of this operation seems to extend beyond the magnitude of weight loss, just not the weight loss, but different hormone pathway for the early metabolic improvement, especially weight-independent glucose-lowering effect of bariatric and metabolic surgery. Current accepted operation, proximal maximal weight loss, and metabolic regulative effect with the minimum complication rate. And current guidelines also support the use of metabolic surgery in individuals with mild obesity and uncontrolled type 2 diabetes. So how we can get the benefit from the bariatric and the metabolic surgery? The first is the most common is diabetes remission also improved. You can see obesity is a major independent risk factor for developing type 2 and more than 19% of type 2 were overweight or obese. The second one you will improve is the fatty liver disease. It defined to NFLD or NASH, but you can start the NASH development because if you do not treat your NASH, you will cause your hepatocyte in the oil and cause its inflammation, and your liver will get into the fibrosis and then become to the cirrhosis. So when you got the body weight decrease, your fatty liver disease will improve. Another is hypertension and hyperlipidemia. You will resolution of your dyslipidemia here to the 60%, and you will decrease your heart attack risk to the 50% and more than the 50%, and decrease 50% to the stroke. You can also, when you got the bariatric surgery to lose weight, you can also to treat your joint pain and osteoarthritis. This is you can see when you the BMI more than 36, for every 5 kilogram weight gain, there is a constant shoot 36% increased risk for develop osteoarthritis. Mortality. Also, when you receive the bariatric surgery, you will lower down your mortality compared to the morbid obese patient. Especially when you got obstructive sleep apnea, when you got your body weight overweight, or you will increase your morbid obesity. A 10% increase in weight was associated with the 6-fold increase in the risk of incidence of ulcer. About 17 to 19% dissociation or improved. And obesity associated with the cancer risk. So when you decrease your body weight, and your cancer risk will also down. Nearly 80% reduction of cancer incidence after bariatric surgery. When women got the polycystic ovary syndrome and infertility, when you unable to infertility, when you after bariatric surgery, you will, and 47% patient will improve. And we can see this in the table 1. When you got a BMI more high, you can got a risk of developing health problem. You can see, especially when you are obese class 3 patients. Now we introduce the method of surgery. It divided to the 3 methods. The first one is restrictive, and the restrictive include left band and the sleep gastrectomy, and the second one restrictive and the male absorption, and exclude Y gastric bypass, VPD, mini gastric bypass, and studies. The second one is a male absorption method, is just the duodenal switch. This is the cartoon picture. You can see the left band. It caused just between the EC junction, and we create a stomach, a small stomach pouch with adjusted band. So when the food into this small pouch, the food detention there, and when it digestion, it passes through many slowly into the big stomach. The second one is the sleep gastrectomy. We can see from the nearly parallel and along the greater curvature style to the angle of his, we cut the nearly 80% stomach to create a gastric tube like a banana. This is called sleep gastrectomy. The three is the lower gastric bypass. You can see we create a small gastric pouch. Then we pour the jejunum to do the anastomosis, and we use the VPD to get the jejunal anastomosis. This part is called bypass because with pancreas juice and the bile juice cannot mix the food, so that this food is not absorbed and digested. The four is the VPD. We done this many not done this because this will cause patient with very serious malnutrition. We see if so, show that 2030 we can see total number of body surgery procedure worldwide was 458,609, and we can see the partner RYGV up to the 45% and the sleep gastrectomy up to the 35%. But we can see this table, and very interesting. From 2011 to 2015, you can see the sleep gastrectomy increase, and we can see the left band is down from the 35 to just about 6%, and we can see the RYGV. You can see though it's down, but it still have 23 to 25%. So why with this picture? Because sleep gastrectomy has very few complication rate and mortality, and the lower gastric bypass, it just has more complication and more high morbidity and mortality than the sleep gastrectomy. And with the left band, why is it nearly disappear? Because its effect is not so good. The patient, you must education every month and what kind of food they cannot eat. So they must come back to clinic for follow-up every month. But in Taiwan or other country, they do not have time to do this. Operation in selection and bariatrics and metabolic surgery. We can see this table. What kind of choice the surgery you will explain to the patient, because we want to consider patient's status weight loss. They want, or this patient is not so mobile person because they their BMI may be 30 to 35, and they got the metabolic syndrome, so they just want to metabolic control. Another is patient's preference, because we will explain every risk or complication for the patient, and the patient they want the procedure they want. Another very important is surgery experience. If your surgery experience is not so good, and the sleep gastrectomy is not so complicated, and technology is so easy, so you must consider surgeon experience. This is very important. The 5 is the facility. If you got a good image and instrument, this is where let the doctors have faith and very safe to do the procedure. But no any surgical procedure is better than another one. Everyone is so equal. Current indication, obesity surgery guidelines through the years change over the time. And I showed at 1978 NIH criteria. They say because the equipment or the technology, laboratory technology is not so mature, so at that time they got a high serious complication, and so they got the age limited, more than 50 years old. It's a contraindication. And till 1991, NIH showed that vertical bending, gastroplasty, or gastric bypass are recommended. Then we see this table. You can see this one. NIH criteria in the 1991 and the 2004 SBS and the current NBS guideline. You can see the age till now. We got an age limitation from 18 to 16. And the patient age about 16, you consider very individually. And the BMI limitation is more than 40 and more than 35. But but in Asia, due to genetic factor, we must decrease the 2.5. So in Asia, we just more than 37.5 or 32.5 with comorbidity. And the comorbidity, we can see this. This syndrome is called Pick-Wheaton syndrome. This syndrome is a hyperventilation syndrome because we have met this patient. If you pre-operation you diagnose this syndrome, I think it is very dangerous to do the procedures for patients with hyperventilation syndrome, because when you intubation to general anesthesia, extubation will become very difficult. So you can see this, we just set a genetic factor. In Asia, we just to reducing the BMI by 2.5 for patients live in Asia, because we do not like the Europe or American so obese. And this technique, we can see this, the recommendation open time is the gastric bypass, sleep gastrectomy, and the laparoscope adjusted gastric bending, also the VPD. And we see this low BMI. When you got the BMI more than 30 and less than 35, if you got a DM and with your poor control, especially your HbA1c more than 7.5, you can consider receive the bariatric surgery to control your sugar. This is recommended. And what are the control indications for the bariatric surgery? In Taiwan, if you do not try any medical treatment for reducing your body weight for more than 6 months, this is very strong. You must receive medical treatment. If you failure and bariatric surgery is suggested. Another is have non-stable and psychological disorder. That's schizophrenia or the bipolar depression and other personality disorder. This is a very serious control indication for the alcohol abuse or drug addiction. Another is this patient is a life-threatening disease in the short term, and the patient who are not able to care for themselves. And you got a second diabetes and type 2 DM with positive antibody, or we can examine the patient, their C-peptide. If you see their patient's peptide is less than 1, and this patient is also the control indication for receiving bariatric surgery. And we will into the second topic is tips, tricks, and complication of surgery. And we will explain to you we do the sleeve gastrectomy and the rule and why gastric bypass. Sleeve gastrectomy is quite so popular because it's got fewer major complications within the first months of the post-operative period. And as MBS also defines sleeve gastrectomy, you can use the parental stage approach if the patient is so mobile based in BMI more than 60 or 50, you have a high risk to do the RYGB. You can do the sleeve gastrectomy for the first stage, and the second stage you can do the bypass surgery for the patient. The sleeve gastrectomy is a restrictive operation, when after operation, you will increase the intraluminal pressure. So pre-op, you find the patient with the GERD. This will post-operation, post-sleeve gastrectomy will induce more severe GERD. But GERD is not really strong contraindication for this sleeve gastrectomy. But you can discuss with your patient, and you can change it to those gastric bypass. And we can see the long-term results of the sleeve gastrectomy. It will decrease 80% excess weight loss, but in the 5 years down to the 50 and 60%. And in 5 years, 20% in the remission rate of the diabetes. But when compared to the RYGB, the remission rate of the DM and the long-term, the weight loss success is better than the sleeve gastrectomy. And I will show you the sleeve gastrectomy in the video quickly. And we create a pneumo peritoneum by the optic direction into the peritoneum. And you can see we put the camera into the trocar and we direct into the abdominal cavity. And we put all the trocar and we will suspend the lever with this instrument. And you can see this is the EC junction. And we can test 5 centimeters from the pulse. And we create a small orifice, detach the omentum and into the nasal sac. And then we see the GIA, and you can see we use the OG tube to push and pull and push to identify that the lumen is not so narrowing because you got so near the OG tube, you will cause the gas tube so narrow and cause many serious complication. And we use another GIA till to the angle of the heat. So you can see that this area is mild within. Remember, do not use electro calculator to do this because it will cause the stability disruption. And you can see then evaluator we just detach the momentum to the upper order or the spring, because when this gastrocolic ligament, its nature cause with host normally so flat, and we cut the stomach, it never caused our gastric tube torsion. This is another complication. Now you can see we use a hammer clip to hammer clips. Now this is the last one to complete cut off the most stomach. And how to hemostasis the bleeding? Just the intracorporeal suture. Do not use the electro calculation to the stabilize, because stabilize will disruption and cause the leakage. So we also put the gas into the abdomen to clean our OP field, and we can save time. You cannot repeat use your suction tube into and in and out, and save many time. And next we